Hey Queens, welcome to the Sister Circle podcast, a podcast dedicated to providing candid conversations, information, and resources regarding women's health, mental health, motherhood, and wellness. And I am your homegirl and host, Fertility. So go ahead and get comfortable, Queen. Let's dig in. Y'all, when I say that I am so excited and grateful for today's guest, I mean just that. We will be having Dr. Soyini Hawkins, who is a board-certified, fellowship-trained, minimally invasive gynecologic surgeon. She also is the founder and runs the Fibroid and Pelvic Wellness Center of Georgia, which is right outside of Atlanta. She's going to be talking to us about all things fibroids, endometriosis, and the treatment options that are associated with each of those conditions. Make sure that you take out your notebook, that you take out the note section in your phone, text a girlfriend, because listen, she's going to be dropping gems of knowledge on the community. So let's dig in. So let's jump into it. I am so excited to have Dr. Soyini Hawkins with us today at the Sister Circle podcast. I feel like, I'm like a girl, I'm a true girl fan right now. So I'm really excited to have you here because of the wonderful work that you're doing. So I've read all about you. I've experienced you from your website to Instagram, right? But I want the audience to know, who is Dr. Soyini Hawkins, and tell us what you do.
Thank you so much, Faith, for having me. I just appreciate your platform and all that you are about and what this podcast is about. I am Dr. Soyini Hawkins. I'm a minimally invasive gynecological surgeon, and I own a practice in Peachtree Corners, Georgia, so just north of Atlanta, the proper city of Atlanta. And with my practice, it has several elements to it. Of course, mainly I'm a gynecologist, and so I work with women on all aspects of their health, but I've kind of subspecialized now in surgery. And the name of my practice is Fibroid and Pelvic Wellness Center of Georgia. So I've actually built myself a bit of a niche, mainly surrounding fibroids and endometriosis and all of the complexities of gynecological ailments that might need surgical intervention, right? But my practice is also well-rounded in that I have brought on another young physician who does women's care and does, annual exams, and we do hormone replacement therapy, and we counsel young women. She has a special interest in adolescent medicine. So we are multifaceted now. Yeah.
That's incredible. Really incredible. But I'm really curious, what led you to this work?
Yeah. So I've always been interested in sciences. I've always definitely, when you're young, you kind of know what grades and what subjects you just excel in. Science has always been a fascination for me. Science and math. Essentially, my parents, my mother's in information technology, and my father and his father and most of my uncles on my father's side of the family are engineers in some capacity. So that math and science mind came easy to me. And I actually wanted to be a nurse. I have an aunt who is a nurse. She was a pretty famous, well-known nurse in Texas. Took care of the movie stars and all the soap opera stars in Texas. And that was what my ambition was, because that's what I knew, right? A lot of times as young women, we want to be what we see. I don't have any doctors in my family. And I didn't grow up with what I would have considered to be examples of Black female doctors that I was exposed to at a young age. And it wasn't until my science teacher in the 5th grade, I'll never forget, Miss Robinson just asked me flat out one day, "You want to be a nurse? Well, why don't you want to be a doctor? Have you ever thought about it?" Mm-hmm. And from there, I had my goal set to be a doctor. It was literally someone exposing me and telling me that I could do it. Women's health, I think, did come more naturally after that, because as I got older and I did start to kind of just come into myself as a young woman and learn more about, children. And of course, you play with doll babies. So, I was interested in just how are babies born and all that stuff. So women's health was an interest probably pretty early on. And from there, I exposed myself. I found mentors. I volunteered, I took opportunities, and it's grown since then.
That's awesome. Awesome. So tell me this, like, as it relates to like your practice, is there any personal experience that's connected to the work that you do currently?
Yeah, it's extraordinary how a little bit of ambition and a lot of just faith in being led has grown into what I do now. I have a personal experience with fibroids. I have my own fibroid story and fibroid journey that backs up about 12 years. To when I was diagnosed, and I would consider it a late diagnosis because my uterus was actually quite large when I was diagnosed, but I was diagnosed when I was asymptomatic. And that's the reason I got to that point without even knowing it. I always joke when I do interviews that I could have been that patient we talk about on that whole, you pregnant and go to the hospital and deliver, you know you was pregnant. One of those things.
Yes. You just didn't know. Yes.
How did you just not feel that baby inside of you? That was me. I did not feel those big behind fibroids in my belly. And so it's my personal journey started and birthed my journey. I went to school to do that fellowship that I mentioned for 2 years after my residency training. So most OBGYNs have had 4 years of residency, learning obstetrics, how to deliver babies, how to do basic gynecological surgery. I went an additional 2 years after that, back to the person who did my surgery. So I had an open myomectomy in 2000. I got married in 2009, open myomectomy in 2010, my first child in 2011. Literally, that's how fast things went around for me. That open myomectomy I had in 2010, though, was the beginning of what has grown into fruition now. I went back and trained with Dr. Fermaretto, who did my surgery, and I literally just told him, teach me everything you know. I wanted to give women an opportunity and the possibility through my passion and you know what I love to do, which is surgery. I wanted to be able to give women more options for what I felt like I had been backed into a corner and didn't have many options surrounding. And that is why I went into minimally invasive robotics, laparoscopic surgery, and now why my niche is mainly around fibroids.
Wow, that is fascinating. I too had an open myomectomy in 2017. I was married in 2016. But I had a miscarriage, and that's what actually prompted me to then have the open myomectomy. My uterus was full of fibroids, but, you know, like a lot of women, I was like, you know, let me do the castor oil packs and let me take all the herbs and whatever I can do to see if I can do it on my own. And I tried, and, you know, my doctor, he said, you can try for like 3 months, but I really suggest that you have this surgery. And at the end of the 3 months, I wound up pregnant, but, you know, it was a, you know, full on experience after that. But I think that the open myomectomy was definitely the best decision that I could have made. However, I think that when I had the uterine fibroid embolization in 2011, based on the reactions that I received from a number of physicians, that may not have been the best decision. But I'll pause on that. So, you know, I think that fibroids just in general is like, you know, is really, it's a common thing, particularly amongst Black women. And I'll say, you know, women of color. But a lot of times I think that people are really, really terrified of like surgery and really just don't know what their options are. But, you know, let's kind of back it up a little bit. What exactly are uterine fibroids, and what are some of the common symptoms that are associated with it?
Sure. So uterine fibroids are benign growths, benign tumors of the uterus. So as women, we're all born with the potential to make fibroids. That's why it affects so many of us. It affects up to 70% of women, 2 to 3 times more in African-American women. And that is because we have uteruses and we have hormones that come from our ovaries. It's just what makes us uniquely women. So with that, we're born with the cells that can potentially make fibroids, and fibroids are just overgrowth of cells in the muscle of our uterus. They're benign, so by definition, they're not cancer. However, they are tumors, so by definition, they grow over time. And they can cause, some of the most common symptoms is very heavy menstrual bleeding, sometimes can cause pain, and many times can cause what we call bulk symptoms. So your uterus and abdomen looks larger. You might even, for some women, look like they're pregnant. They could have urgency of urination where they pee all the time, or constipation, or back pain, or discharge. There's so many symptoms that's associated with fibroids, and heavy menstrual bleeding by far is the most debilitating one that many women have.
Yeah. And so with the heavy bleeding, there also would probably, for some might also come with like an iron deficiency.
Yeah.
Anemia. Absolutely. Okay. So those are some of the common symptoms.
Sure.
So our fibroids, both of my sisters, they're my half sisters, but both of my sisters had hysterectomies. They're all significantly older than me.
Sure.
My mom also mentions having had fibroids. So one of the questions that I often have heard people ask is, are fibroids, are they hereditary?
Yeah, so there's a lot of components to fibroids. I tell patients it's multifactorial. So there's a genetic component. We do see it in lineages where, just like you said, my sisters, my mother, my grandmother had it. Even if they didn't talk about it, I know grandma had a history of something, and they told she used to have heavy bleeding. She probably had fibroids, right? We do see that, but not just genetics, not just hereditary. It's environmental. It's the things that we eat and put on our skin and our hairs. It's vitamin D deficiency that, messes up with our just natural inflammatory reactions. And like I said, it's just as women, there are many women that they're the first in their family to be diagnosed with family because, like I said, we're all born with the potential to make them. But yes, there is a hereditary factor to it.
Interesting. So you said there's environmental factors, there's all of these different things. What about as it relates to fibroid growth? So my experience with fibroids was very interesting in the sense that I felt like both of the times in which I needed to address my fibroids because they were, my symptoms were just out of control, were both in very high stress times of my life, particularly around work, right? I've always worked in not just, fast-paced kind of work, but super fast-paced, and the stress was up there. Yeah. So in my mind, I would tie or correlate that with the growth of my fibroids.
Yes.
But scientifically, is that true?
Scientifically, it's true, but almost in an anecdotal way. I don't know if we can say that there's hard science or that anybody is answering that question in a systematic way that can be easily measured and then reported, right? But just because we're not reporting it and it's not in some literature search doesn't mean that it's not true. Anecdotally, and from what I see in my patients and testimonials like you just gave, and even testimonials in my own life, stress absolutely has a factor in how the fibroids manifest itself, right? May it be in the growth of the fibroids, but definitely in the symptomatology. And even if we think about our mental health and what stress does to our mental health, that impacts our body from head to toe. Stress is a component that I don't think we talk enough about in every realm of our health. Maybe if you're hypertensive or diabetic, or if you have renal failure, or if you have thinning hair. You know what I mean? Mm-hmm. Stress actually plays into all of those things and how our body reacts. So yeah, we might be born with the genetics for it. We might have the cells for it. We might not eat the greatest food all the time. That stress component is something that sometimes we can control. Sometimes there's factors where we can do something about it. But to acknowledge that we definitely feel different when we have more stress in our lives is super, super important to be able to address it for what it is.
Yeah, absolutely. And so tell me this, I really am curious. I think that, I think I read that about 70% of all women by the age of 50 will have experienced fibroids in their lifetime. Right. But for African-American women, that percentage is about 80%.
Correct.
And we experience the symptoms a little bit more prevalently and things of that nature. So I'm wondering, why Black women? Why do you think that is?
Yeah, for everything that we just talked about, if we think about our lineage and hereditary factors, if we think about what type of fibroids we see and grow in the African continents, they're usually more aggressive in younger women. So it's not just that women are getting diagnosed later or it's missed. Sometimes in young 20-year-old women, African American women, we see that it'll be a bit larger on presentation or more symptomatic. And I want to be clear: fibroids affect all women. They see no color, no creed, no culture. I mean, I have patients, Asian women that are, about this big even, and they have huge fibroids. So it's actually a pandemic in and of itself. With African American women or Black women, it's a couple of other factors that might go into it, such as culturally the things that we consume and eat, right? Mm-hmm. The yams, the rooted vegetables, which are good, but also very starch heavy. And the yam has a lot of estrogen in it. And even in the components, if we even think about just socioeconomic status of preserved foods with preservatives and foods that have just are not the healthiest for us in our communities, those do play into it. And I'm not a big fan of the theory that obesity is the reason that Black women have more fibroids. I don't think it necessarily correlates directly to obesity, but it does correlate to our food consumption and the type of things that we eat. It also correlates to historically what we use to process our hair. There have been definitely good literature to show that there's a relationship between the paraffins and the environmental chemicals that we put and the things that are on our skin and in our beauty regimens that will make us disproportionately more susceptible to it. And then also our melanin, because it blocks vitamin D. Vitamin D deficiency has been heavily linked to fibroids. And even in my Caucasian patients with fibroids, the great majority of them, at least 80%, have vitamin D deficiency as well. Even without melanin, for sure, it definitely is a factor that puts us up, edges us our risk factor up a bit, because our melanin blocks that natural vitamin D that we get from the sun. And we need vitamin D to help fight off naturally inflammatory factors that will feed things like fibroids. So we have a couple check marks that we check off that gives us that 2 to 3 times higher disparity when it comes to fibroids and the symptomatology of it.
Wow. So you talked about vitamin D and being kind of like one of the nutrients that we are deficient of. With women who have fibroids, what is there like an abundance of as it relates to particularly hormones? So is it estrogen? Is it progesterone? Like, what is it?
Yeah. So I laugh because there are a lot of theories out there. Hormones, period, right? Mm-hmm. Hormones, period, the imbalance of hormones. So too much estrogen versus progesterone. There are some good literature by notable scientists that look at rat studies and look at progesterone. And some will even say that the actual true causative factor of the bad hormone is progesterone. The most trusted theories, though, the ones that are most easily quotable and kind of stay when it even comes to drug therapies that are out there, has to deal more with the estrogen and the estrogen component when it's higher in our system and there is an imbalance as to what feeds fibroids. And that's why, like I brought up earlier, even the obesity factor or more fat cells, because fat cells convert to estrogen as well, will feed fibroids. So there's a couple of different ways that we're getting estrogen. We naturally make it from our ovaries, we get it from our fat cells, and then we consume it in our food. And all of that can perpetuate fibroid growth and symptomatology.
Gotcha. So when you said we consume like estrogen in our foods, what types of foods might that be?
Child, beef and pork. Those are the top 2 culprits. Top 2. That was the first thing I gave up when I went through my fibroid journey, was beef and pork. I crave a pepperoni now, but I'm not putting it in my mouth. Okay. So beef, pork, processed foods. Like I was saying earlier, fast food, McDonald's, Burger King, all the things that they put in there. I mean, when your tongue tingles after that real juicy hot fry that you got from McDonald's, and it tastes so good, and it was so good to your soul, and then you're like, but why is my mouth tingling?
Right,
I know
right.
something ain't right because my mouth shouldn't be tingling, right? Why is that fry that I dropped a week ago still look like a fry from this morning,
Right,
right?
right.
You know something's not right about what they're adding and putting into those foods, canned food. There's a reason there is a high shelf life on our canned food because they add preservatives to it to be able to do so. Dairies, the milks have a lot of hormones in it. I always encourage my patients to just get closer to the earth. When we talk about nutrition and fibroids, I tell them if you just think simply, make things very simple for you so you don't overthink it or over analyze what might be the right moves to make. And just think, Dr. Hawkins said, get closer to the earth. So if I'm eating and consuming things that are going to be, green, fresh, they're going to be less processed to it. They're going to be coming from the farmer's market or from my local, corner market that I know came straight from the farm. That's going to be a healthier, plant-based is going to just be a healthier way to consume your foods.
Mm-hmm. Very interesting. So I want to move into talking about like the different treatment options that are out there. A large reason that I wanted you to come on is because I think that I don't think that there are as many minimally invasive gynecologic surgeons that are out there, and people are more apt to go to like the old school OB-GYNs, who, basically, it's like you got a couple of options, right? And I really want to expand the toolkit of options as it relates to fibroids. And so can you share a little bit about what are some of the most common treatment options and why in general as it relates to fibroids? And then you can talk a little bit more about where your specialty kind of comes into play.
Sure. So the gold standard kind of what I would say is what bread and butter, just what we learned and were taught in school as ways to manage fibroid really comes into two categories, myomectomy and hysterectomy. Either you're going to remove the fibroid or you're going to remove the uterus. That is what we all learn or are taught in our residency training. And usually in an open procedure type of way, especially when you're thinking about larger uteri because the fibroids have grown them to be bigger than their normal fist size. So myomectomy is just basically finding the fibroids, making an incision, cutting and removing them and suturing that body of muscle back together to make it as normal as possible, usually to support a pregnancy. And then hysterectomy is obviously removing the entire uterus with the fibroids, not the ovaries. It's just the uterus and the fibroids. Don't let nobody mess with your ovaries. And so that's the basics that most gynecologists should be able to offer their patients. I'm a minimally invasive gynecologist, meaning that, like I said, I do 2 years of fellowship where I operated 4 out of 5 days a week and learned how to do robotic and laparoscopic and hysteroscopic surgery. So I learned how to do surgery through very, very small incisions, not for cosmesis, but literally just to cut down on some of the complexities of performing the procedure and in that the complexities of healing from the procedure. So with that minimally invasive approach, my patients are able to, get up and move faster, get back to life faster. They get back to their productivity and their families faster. They have less pain. During surgery, I have less risk of blood loss, complications, adhesion formation, some of the things that scare people from just going to the operating room. And I, the reason I got into this is because I feel like we deserve those options for fibroid management. So I do specifically for fibroids. Probably the most minimally invasive procedure I do is laparoscopic, what's called radiofrequency ablation, where I actually just shrink the fibroids with heat, with radiofrequency energy through a needle that I laparoscopically visualize and see and put into the fibroid under ultrasound guidance. And then I do myomectomies, so traditional myomectomies as well. And with that, I usually do it laparoscopically, again, through very small incisions, usually robotically, which is just a machine that helps me do a laparoscopic surgery. So still laparoscopic surgery, same risk factors for you. It just makes the surgery easier for me because there's a lot of suturing involved in a myomectomy where, again, making an incision, cutting out the fibroid, suturing that muscle back up, same steps, just through smaller incisions. So you heal faster. And then I do open myomectomy. Sometimes women come in and they're looking for a laparoscopic or minimally invasive approach. That's why they found me. But the reality is the safer surgery would be to do it open. But I do also implement minimally invasive techniques even in that. I'm usually able to do it through smaller, what we call mini laparotomy incisions. And again, use techniques that are not as damaging to the tissue. So again, my patients go home the next day. If your incision is this big or this big, you go home the next day.
Wow.
And then the last thing is hysterectomies. I offer it in a laparoscopic or robotic route. Again, even when the uterus is above the belly button, I usually can do it robotically and offer that patient the minimally invasive option. And then with the myomectomy, the only one I didn't mention was hysteroscopic, meaning going through the cervix into the cavity, which a lot of gynecologists across the board, we learn how to do that in training as well. I usually do that sometimes in combination because I don't want to just remove the ones in the cavity. Because if we know anything about fibroids, they can regrow. And sometimes regrowth is just the one that was there that the doctor didn't remove.
Yeah. So let's talk a little bit about that particular procedure a little bit. So it's very interesting. I feel like out of maybe 5 girlfriends who I've talked about fibroid options in the last year, all of them have been, that particular procedure has been suggested where they go into the vagina, or you said the cervix, and then they kind of remove one of them, right? My question is this, like, and then a lot of times I think out of 5, 4 of them, the doctors have said, oh, we got to go back in and we've got to, remove another one.
Yeah.
And it's like, I'm not a surgeon, obviously. I'm like, I don't know. That just doesn't sound right. Why is it always suggested? What are some of the downsides of it? And, like, does it cause a lot of scar tissue?
Sure. Those are reasonable questions. So hysteroscopic myomectomy, that's what that one is called, where we just go through the cervix, look inside with a camera and remove just what we can see in the cavity. We can't remove what's in the muscle, well into the muscle, or what's on the surface closer to the skin of the uterus. Lots of benefits to it. Obviously, it's minimally invasive. So, because I'm not making any incisions on your abdomen, like you don't even have to go under full general anesthesia to do that. So if someone has a fibroid that is only in that location and wholly in that location, that's the best way to remove it. It's going to give them the fastest recovery. I mean, that's like 3 days and you back to it like ain't nothing ever happened. And it dramatically improves heavy bleeding. So some doctors will offer it mainly because they're dealing with the symptomatology of that fibroid in the cavity. And they'll tell their patients, if I remove this one, you should do much better with your bleeding. What they also need to follow that up with is if you have other fibroids in your uterus, I'm not going to be able to get to those. So you might still have a heavy cycle, or we might likely have to do surgery again in the future, again, depending on where those fibroids are located. So that might be what happened with some of your friends. The risk when it comes to adhesion formation, yes, there is risk of adhesion formation in the cavity, which is a super important area because that's where babies go, right? That's where babies grow. But if certain techniques are applied, like I put in a lot of what we call intrauterine balloons. If I know that I've distorted or basically taken the fibroid off a large area of the cavity, then I'll put in a balloon that will help stretch it open until it heals a bit. And that cuts down risk of adhesion. So there's lots of things that can be done to decrease that risk too. Because like I said, you can go from night to day when you have that procedure done if you have a fibroid in the cavity, because those are the ones that bleed. The unfortunate reality is, though, a lot of times, sometimes the doctors will do it and they can't remove the whole thing. You can't, if you leave a portion of it, the symptoms aren't going to change. You know what I mean? Right. Like there's still a part that's pushing into or up against the cavity. So they'll still bleed heavy, which is unfortunate. That's why I say I usually do it as a combination procedure, because Dr. Hawkins taking you to the OR, I'm going to offer you the option to remove all the fibroids. We're not going to talk about just removing one. If you really, truly want us to remove all of them. Have I ever taken someone to the OR and just removed the one and left the others? Yes, but that patient made that decision. That's all that they wanted to do, either because that's all they had time for. They couldn't take off no more than that 1 day or 3 days, or whatever it might, let's do it on Friday and be back to work on a Monday. And it was going to give them some symptomatic relief, right? Because it's a process. It's a partnership in making these decisions. But the reality, unfortunately, with a lot of medicine is a lot of doctors will only offer what they can do. Mm-hmm. So they're like, nah, I can't tackle those other ones, but I can get this one. So let's take care of this one. Which is not necessarily fair to the patient, because they probably should say, maybe you should go talk to the doctor down the street who could take care of all of it, and then make a decision. Mm-hmm. This is what I can do. This is what's in our community that someone else might be able to do. And it actually might be a better option for you or get you a more total treatment. And unfortunately, there are plenty of doctors that aren't telling their patient that they have other options or other choices.
Absolutely. Absolutely. So what about, what are some of the options that are suggested for those who aren't just looking for like relief from symptoms, but are also looking to preserve their fertility?
Yeah. So the two that I do the most often are the radiofrequency ablation laparoscopically, and that's called Acessa. That's a name brand of that procedure. And myomectomy. So those are the two uterine sparing options. Uterine artery embolization, I would consider that minimally invasive approach or minimally invasive surgery, even more minimally invasive than the others. The hesitation that I get around fertility is that it kind of leaves things a little bit unknown. Have there been pregnancies after UFE? Yes, clearly. You know that.
Yes, I did.
You get pregnant after UFE. Unfortunately, the reality of a lot of women, though, is that they can't. It really does take away a lot of options surrounding fertility, because it's blocking the blood flow to all of the vital parts of the uterus too, not just the fibroids that are essential for pregnancy. Or if they are able to get pregnancy, sometimes they have very tragic outcomes, losses, placental abnormalities, and complications surrounding their pregnancy. So instead of leaving things up in the air for those possibles, a lot of times we won't recommend that patients get a UAE if they're desiring a fertility. Acessa, the radiofrequency laparoscopic ablation, is just treating the fibroids. So I'm not destroying any healthy vasculature. I'm not messing with the cavity and where the baby is going to be. I'm literally shrinking the fibroids, which take care of the symptoms and the bulk and the discomfort, and a lot of times even the distortion that might be preventing someone from getting pregnant. So that's a safe one for pregnancy. And then obviously with the myomectomy, we're removing the fibroids from the muscle. Yes, suturing it up. Yes, making that muscle area weaker. That's why a lot of people have to have C-sections for delivery. I had 2. After my open myomectomy for my 2 sons, I had 2 C-sections. But, people get scared about the scar tissue. Trust me, that scar tissue ain't making your uterus worse off than the fibroids are. Mm-hmm. That's really honestly the way I have to lay it out for many patients when they say they're scared to have that surgery because they feel like it's going to inhibit their fertility. And then the reality is that you don't always have to do anything. Many women get pregnant with fibroids as they are, and have beautiful, wonderful pregnancies. Again, what we cannot predict is how the fibroid might actually behave during the pregnancy. Will it grow? Will it make the baby not grow, as well as it should? May it cause preterm delivery, or will it make you have to have a C-section? Those are all the possible complications of a pregnancy with fibroids. So there's a good spectrum of options surrounding fertility and fibroids, including doing absolutely nothing and just going ahead and getting pregnant, even with those fibroids in place.
Awesome. It's good to know about those options. I want to go back a little bit to the whole UFE, right? Uterine fibroid embolization. So I was actually diagnosed with fibroids when I was 20, I think I was 26. And at the time, so I'm originally from LA. And at the time, so Stevie Wonder has a radio station, 102.3. And I just remember on the radio, all you would hear is like, are you suffering from fibroids, right? Are you trying not to be out of work for a long time? Uterine fibroid embolization is kind of where it's at. And then I had a girlfriend who had actually had UFE maybe a couple of months prior to my diagnosis. And she was like, girl, you should just do that. I was back to work in no time.
Yeah.
So I remember when I had, and my doctor, my surgeon, he told me that if I were to get pregnant, that, it would likely only be through IVF. So he had referred me after my open myomectomy to go to this fertility center. So I gone to the fertility center, and I remember it was a horrible experience. And so the doctor was like, well, I don't think that you're going to be able to get pregnant, but, you know, we can try. So she leaves and comes back, and she was like, wait a minute, did you have UFE or did you have UFA? And I was like, I don't know. Like, what's the difference between the two? But I remember being so angry and saddened. Like, I called the doctor who had performed the UFE, his office, and I was like, why would you have done that to me? And I was I was 26 years old. And he said that the procedure that he had done was like, instead of it was like a gel that he had put into the arteries, and then, you know, after a short while that it kind of like dissolved.
Yeah.
And so as opposed
temporary treatment.
Yeah. So but I also hear that that's a similar process is done for like women. I don't know if it's giving birth and they're hemorrhaging, but like, yeah. So I don't know. I think that it did actually, like, I had a cesarean, and my doctor, Dr. McNair, I love her to pieces. She was like, I had no idea what the hell I was going to see when I opened you up. Yeah. And she said, but like, even up to now, I have no fibroids. Yeah. And I had an open myomectomy in 2017, right? Yeah. And so I think that the benefit of UFE was that it even got like the little seedlings of fibroids and kind of calcified those. And then when I had the myomectomy, they kind of like did a clean sweep. So
yeah. So why did you have to have a myomectomy after your...
Oh my God, because I had like my fibroids, I had a lot of fibroids. So when I had my myomectomy, they removed 19 fibroids. Sure. The largest, it was a pedunculated, which means that it's attached to the uterus by a stalk, right? Yeah. It was the size of a grapefruit. And so I was that woman who had the fibroid belly, who possibly looked about 5.5, 6 months pregnant, but you don't want to ask because that belly's been there for a long time. Sure. That was me. And so, you know, my doctor said that if you want to have a successful pregnancy, you need to remove these fibroids.
Got it. So you had a pregnancy after the myomectomy, not after the UFE.
Correct. But yes, so that was correct. Mm-hmm.
Yeah. That's interesting. They did it that way, because that's not typically how most would do it. And I'll tell you why, but finish up your story.
No, I was just going to say that at the time that we're recording this, I'm also pregnant. I'm 8 months pregnant with my second child. And I haven't had to use IVF or anything, not to say that there's anything wrong with doing so, but I'm just blessed. And this is a large part of why I want to put this message out there, that no matter what it may look like, that it is possible to have the desires of your heart. So
that is awesome. Congratulations.
Thank you. But you could go ahead. What were you going to say?
No. So I want to piggyback what you just said, because that is why I like to tell my story too. Okay. I feel like we so many times, and this is across the board, like when people, I love that my patients write wonderful reviews. Like I love when my patients are like, I had a great experience and I want to tell people about it, because people read reviews and we look up everything, right? If I'm going somewhere and I want to go to a new restaurant, I read their reviews.
Oh yeah.
Because a lot of times we'll get caught up on all the bad ones. And sometimes for certain instances, the only people leaving reviews is when they have a complaint to make, right? Mm-hmm. And so telling our stories of success, I feel like empowers so many women to feel hope in this journey, because there's so much out there to talk about. My fibroids grew back. I had this horrible experience. I had this horrible surgery. You know, it just makes you feel like you're hopeless. Mm-hmm. So when people like myself and you do, Faith, share that we had this fibroid journey, we went through it, we suffered through it maybe a little bit too. Mm-hmm. And we came out on the other end feeling more whole, feeling more freedom, and accomplishing pregnancy and the beautiful gift and blessing of motherhood. I tell people about my journey all the time. I'm 11 years past my myomectomy and not one fibroid has grown back. I did not get a UFE.
Yes. Right.
Did it, right? So I like that success story and sharing that so people can see that there's a lot of hope in getting treatment and actually just getting it taken care of. Or at least changing your lifestyle, right? Doing something, not nothing. About the fibroids, about the hand that God has dealt us, right? Absolutely. That's really what. When it comes to UFE, so I'm glad that you clarified how you had yours done, because that is not typical. That's actually not typical, and I'll tell you why, and why it was great for you. It was great for you and for anybody that desires pregnancy to have that temporary placement of pellets. And it is exactly how we do it for postpartum hemorrhage, because it's temporary. Those pellets will actually occlude and block the blood flow to the fibroids in the uterus as total for a period of time, and then they dissolve. So then they get out your system. So when patients have postpartum hemorrhage, we need to stop the bleeding, occlude those vessels, and then a period later, we want those vessels to open back up and basically feed the uterus so that they can get pregnant again, right? That's what they did for you. So you had a temporary treatment that if you had, you ended up having to have something else, a myomectomy, because it wasn't a fixative. It was more like a Band-Aid for that period of time, which works when you desire future fertility. Unfortunately, most interventional radiologists don't do that. They do a very permanent procedure, and it's the permanency of uterine artery embolization and uterine fibroid embolization, because most interventional radiologists, that's the same procedure. There's something now called selective uterine fibroid embolization, where they try to actually specify more of the vessels that are going just to the fibroid to try to specifically kind of occlude just those vessels. That is still kind of being researched and worked, and the technology and the ability to do that is not broad, because of course that means that it's a much more high level type of procedure. With that though, unfortunately, the success is not as good as when they blast your uterus, right? When they just stop the blood flow to everything, then everything gonna die off. We're gonna be good. Your bleeding's gonna get better. You might even stop. When you're seeking fertility, that is like I said, it's a gamble. There are many women that get pregnant after UFE. There's many women that will never get pregnant after UFE, even with IVF. And there are a lot of IVF and reproductive doctors that won't even accept a patient who's ever had that procedure because of those rates, right? If you get that uterine fibroid embolization in a selective way, or in the way that you got it, that was not permanent, that was either semi-permanent or temporary, it usually won't last, because you're a young woman, you still have estrogen, that vascularization will come back and it will feed those fibroids. And that's all it takes for the fibroids to grow. And so you had a myomectomy after, your circumstance probably would have been very different if you hadn't had your myomectomy for that exact reason. And unfortunately, I see a lot of patients who have UFE, and after a few years, it worked well, and then they have a failure because those fibroids have found new blood flow or found new vascularization, and now we're back having the same symptoms, and you have to have a second procedure. So generally, the rule of thumb is don't do UFE until you're finished your fertility. And I pray that over the next few years that we do find a way to make it better for patients that are seeking a fertility on a broader level, and they can have the success that you had, because it's a wonderful option. I'm all about option for women. But the truth behind options and making sure that patients are fully informed, so they're making a well-informed decision, and they don't call their doctor back like, what did you do to me?
Yep.
It's super, super important.
And I think I think that I learned so much from that. Excuse my French, but from that fuck up, because, and what I mean by that is that I had a friend of mine who had done the procedure. So I was like, oh, well, she did it, I'm going to do it.
Sure,
I didn't do research. I didn't do anything. Right. And so, but when it came to my open myomectomy, I was like the exact opposite. So, let me tell you how extensive I was. I was driving myself crazy, because what I was trying to find was someone who had the same story as me and who had the success that I wish to have, who had UFE, had an open myomectomy, and had the outcome that I wish to have. Sure. So as for the physician who did, or my surgeon who did perform my surgery, I spoke to two of his patients. There was one woman who had written a review and had updated it twice on Yelp. I talked to her and spoke with her. She had an amazing and nothing but good things to say. And then he actually had given me the contact information of someone who had had the procedure, and it was so reassuring. But also, like, I think that, like you said, like, it's so important to leave reviews and to understand that, you know, it's so important. And that's why, you know, for me, like, having this conversation, a real conversation with you, is so important, because the more educated we are, the more empowered we are to make wise decisions as it relates to our health.
Yeah. I tell my patients, I'm like, honey, if you leave with nothing else but understanding what's going on with your body, literally just education on what does this ultrasound say, or what does this MRI really say? How do my symptoms actually link to the position, location, and size of my fibroids? What is going on with my body? And what options do I have, from lifestyle modifications all the way to a hysterectomy, if that's the right thing for me. But that education piece is so empowering.
So empowering.
So empowering. Yeah.
So empowering. So, okay. You've got women who they get the open myomectomy or they get the Acessa, and they're trying to conceive. A year passes, right? Maybe 2 years pass. Why might some women struggle after post-op in trying to conceive?
Yeah. A lot of the question also has to lay in what else has been worked up and what else might be going on, because it's easy enough to blame everything on the red herring, right? Fibroids are easy to diagnose. You just need some imaging and you see that they're there. But things like ovaries that aren't producing good eggs or functional eggs, sperm that ain't swimming, child, or blocked tubes, you can't see that on the surface. You can't pick that up on simple imaging. If that is not actually investigated and worked up, you just will never know. So there are a lot of women that will get to have fibroids taken care of first, either one, because they haven't been able to get pregnant, or two, because they're just symptomatic. Like, from month to month, I'm hemorrhaging. I can't live like this, right? And so you need to get the fibroid taken care of anyway. And then they'll discover, like you said, a year has passed and I haven't been able to get pregnant. You know what I mean? Thank God for our success story, but not everyone has the same. I always tell patients that fertility is complex. It is not just about your uterus. Your uterus is the vessel that carries it. It's super important in the game. You can't do it without it. But there are lots of working things that have to go into play. What is your thyroid function like, right? Are you making eggs every month? Do you have PCOS? Do you have endometriosis and adhesions? Is that tube blocked? Is your partner's sperm swimming, right? Are you having sex the right way? Are you even having sex on the days you're supposed to be able to conceive? So there's so many factors that go into getting pregnant. It's not always just a fibroid. And fibroids actually only maybe can account for about 15 to 30%, depending on the source that you're reading, of infertility. So it's not always the biggest factor. Yeah, we think it is because we talk so much about it, and there's so many women that suffer from fibroids. But like I said earlier, there are many women that are never diagnosed with fibroids until they're pregnant. They don't even know they have fibroids until they got that first ultrasound when they were pregnant. So it's not always the culprit, and the surgery is not always the culprit. Doesn't mean that you have adhesions from the surgery and that's why you ain't getting pregnant, right? If you hadn't been able to get pregnant for the last 10 years that you've been with your partner, and all of a sudden you discover you have fibroids, it doesn't mean that all those 10 years of fibroids were what was the problem. So it's complex. It's complex. And one of the things, especially in the Black community, that we do is we will not get diagnosed. So women that have fertility issues, historically, Black women will wait much longer than the recommended time to wait. We will be 42, right? And like, I want a baby now. And their friend, their doctor, their mama told them 10 years ago to start to look into that desire, if it is a desire of theirs. And not to say that they were ready, not to say that it was appropriate for them to get pregnant at that time, and not to say that they should have, but we will wait, right? Their doctor will suggest that you look into egg freezing. You know, you're 35, you know, what are we planning on doing? I know you get your graduate, you're on your third degree.
Right, we'll have all these degrees.
Girl, if this is truly a desire of your heart, what are we doing to prepare for that? Or at least seeing that we're going to be able to keep that as an option. that is where we fail sometimes. And sometimes it's just because we just don't know. We just don't know. My story and your story is different, but there's so many women that I have so many friends that are my age now that are just not trying to get pregnant and just not realizing that they're going to have a problem doing so. But the last 30 years of their life, all they've been worrying about is not getting pregnant and birth control and not getting knocked up, right?
Yep. Yep.
And now they're ready, and we're discovering that it's not as easy as we thought it was going to be. That, unfortunately, is a tragedy that we hear too many times in our community, because we're just not getting worked up.
Right. Well, you know, the Kenya Moores and the Candy Burses, I think that's how you pronounce her last name. You know, they make it seem like, you know, Kenya's damn near 50 and Candy about 45.
That Holly Berry, that, you know what I mean? Like that, Janet Jackson, girl, you know how many times I got folks coming 47 talking about Janet did. I said, you got Janet money.
Right.
You got Kenya Moore money. You got Candy Burris money.
Yes, yes. But you know what? I have a girlfriend, was 47 when she had IVF. It took for the first time when she became a mom. But it's just like that, you know, those are like one-off stories.
Yeah. Oh, but they're options. That's good that you even share that, because I tell my patients that are, you know, in their 40s, I say, you can get pregnant. You definitely have options around, and you can do it. As long as you're healthy and have a uterus, you can get pregnant. They can give you the hormones. You can go buy a baby. You can go buy an egg if you want, and a sperm to come with it if you want. You know what I mean? So it's not that it's impossible to do, but you have to know the options.
Yeah. And, you know, it's unfortunate. I think that, you know, alternative options like IVF and egg, you know, what is it? Egg freezing, like all of these different things, right? It seems like it's like hush hush in our community.
I know. It's so
and it's just like, why? Like, white folks been doing this all of their lives. Like we have options
for their grandchildren.
Yeah. And it's like, there should be no shame in this, you know, no shame. And so I think that it's really important to, you know, let folks know not only what their options are as it relates to, you know, managing, you know, their fibroids, but also what their options are as far as conception too.
Absolutely.
So I think that this conversation is giving me another idea for a show topic.
Yay! I have that conversation in the same beat, like in the same setting when we do consults. When I do consults with my patients, that's the last question I always ask. What are your plans around fertility? Because it should be a part of the discussion. We should talk about how this surgery may or may not affect it.
Absolutely, right? Absolutely. So what about this? So women, you know, I'm still in a lot of the fibroid like surgery groups and stuff like that on Facebook, and everyone's like, well, how long should I wait to try to conceive after I've had one of these surgeries?
Yeah.
And, you know, like, I would assume that it depends on each woman, right? And the type of procedure, but what would you generally say?
Yeah, I agree. It depends on the procedure. Really, honestly, if you do a hysteroscopy, you may have to just wait another cycle. You know, even when you talk to reproductive specialists, they base that wait period on, well, really two factors. What type of surgery did you have, right? And what was the state of your uterus? And then your age. Because sometimes we ain't got no time to play. Like, come on, let's get this thing popping. If you have a hysteroscopy procedure, because that's not usually cutting into the muscle and requiring that suturing, you can start your process faster, maybe after a cycle or two. Same thing for the Acessa radiofrequency ablation. I usually request that my patients wait 3 months, because the average shrinkage is 45%. Most of that shrinkage will happen in the first 3 to 4 months. So I say, you know, get most of the shrinkage out of the way and then pursue the pregnancy. And then for an open myomectomy or a robotic myomectomy, it depends on how much work was done on the uterus. If I just kind of took off a pedunculated fibroid that was on a stalk, kind of cut it off like the top of a lollipop, girl, please go on and, you know, do your thing the next month or two if you want. But if I actually cut into that muscle and I had to suture it up, then I do want you to wait 4 to 6 months. Usually my patients that are about 36 37, 38, 39, 40, I'll say you can start trying at 4 months because the chances of them getting pregnant right away is much less likely. I really don't want them pregnant until 6 months. But if they're 30, I'm like, you got to wait 6 months. I want that uterus fully healed and as strong as possible, completely scarred in. Scarring is not a bad word. Like scarring has a reputation to be like, ooh, don't use scarring when you talk about the way I heal. That is how God made us to heal. That is how we heal. We form scar. That uterus scar needs to be as strong as possible before you get to put a baby in there and it starts to expand, right? So 6 months, generally speaking, is the rule of thumb for pregnancy, but sometimes we'll tell you to start trying earlier because we know it may not just happen with 1 or 2 ovulation cycles.
Gotcha. So one of the things that you talked about was like how fertility, it could be a host of other things outside of like fibroids. Mm-hmm. So is this a conversation that you suggest women having with their OB-GYNs, or would you suggest that they broach the conversation with like a reproductive endocrinologist?
Yeah, so I clearly believe in subspecialties because I'm a subspecialist, right? So I clearly believe that we all have a lane. OB-GYN is a fantastic preconceptual counselor. We all learn how to do preconceptual counseling. However, if you're 40 and you've been trying for 2 years, you already behind the ball. You need to go see a reproductive specialist. They need to start doing that workup. Your obstetrician can probably start the workup, but to have that in-depth conversation, most obstetricians would recommend that you go see someone anyway. Now, if you're 29 and you just got, married and you're ready to think about pregnancy in the next couple of years, then that's the safe conversation for you to just have with your OB-GYN. They're going to talk about prenatal vitamins and nutrition and, ideal body weight, all those things that are going to prepare your body for a healthy pregnancy. But when it comes to the point where you're like, I'm over this age, generally speaking, infertility is considered 1 year of very true trying, meaning like I'm using an app and tracking ovulation and having sex on the right days, and it hasn't happened in a year, you're considered infertile. You need to go see a reproductive specialist. If you're over the age of 35 and in 6 months, you haven't been able to get pregnant with trying, very persistent trying, then you need to go see a specialist, which is a reproductive endocrinology specialist or REI doctor. The OB-GYN can do preconceptual counseling, but to get in depth, I believe in subspecialization.
Gotcha. So, it's funny, what actually brought me to seeking out my surgeon was the fact that I had been experiencing like hair loss. I had a bald spot that was in the back of my head that was like the size of my fist, and I've always had like long hair. Like, sure. What is going on? I also had gained like 20 pounds in 3 months. I'm only 5'1.5". Sure. And like my skin just was like breaking out like crazy. And so I had gone to one doctor, mm-hmm. and she had run like some basic tests, and she was like, oh, everything is fine. And I'm like, there is no way everything can be fine. And so I'm like, well, I need to be addressing my fibroids anyways. Let me see if I can find like, a specialty doctor. Sure. So nevertheless, when I first had gone to him, I was telling him about all this, and I was actually misdiagnosed with PCOS at the time. Mm-hmm. But then he had done some further testing, and it wound up that I had like hyperprolactinemia. Yeah. So basically I had a super high prolactin level. Yeah. And so that wound up being kind of like a dual diagnosis of, your fibroids are out of control and you've got this hormonal problem that's going on, to the point that they thought that I had a tumor on my pituitary gland.
Right.
So, but I was only, I think I was, early 30s at that point. Mm-hmm. Yes. So for someone like that, is that a conversation that you would have with a regular OB-GYN?
Yeah, absolutely. Okay. 100%. So a reproductive endocrinologist is an endocrinologist. So they are subspecialized, and they probably would be more apt to do all of that workup, even if you're not trying to get pregnant per se. They're mm-hmm. endocrinologists. They do manage PCOS. They're going to be the best in our specialty for any type of endocrine dysfunction, which prolactinemia is. Most of the times when patients have prolactinemia, women will present with some type of dysfunction of their menstruation or something that just will bring them to their women's health doctor. And they can get to that diagnosis. And then many times we'll even send you to an endocrinologist of some sort, a regular general endocrinologist or a reproductive one. But most obstetrician gynecologists can work that up and get those testing. It sounds like just unfortunately your OBGYN just didn't order that prolactin. They just didn't order the one test. They probably ordered everything else because in their mind, they probably were thinking PCOS, right? But it's an endocrine disorder, clearly based on the symptoms that you've had. So that full panel, thyroid, prolactin, testosterone, like all of the hormones, estradiol, like all of them would have been a bit more appropriate to make sure that even if 90% of them are normal, that one abnormal test will tell the story.
Gotcha. And so for those who may not know what an endocrinologist is or what the endocrine system is, it's the hormones, right? So they're the hormone doctor. Okay, awesome.
Everything. They're the hormone doctors, correct.
Oh my gosh. So I think that as we talk about, more education, right? So for women who are, seeking out like next steps as it relates to management of their fibroids, what are some of the questions that you suggest that they ask their doctors? And what's some of the like independent research that you would suggest that they do before, figuring out how best to move forward about their treatment options?
Sure. So the independent research, I think a lot of times will come first because a lot of times that's how you'll find your specialist if you feel like you need a specialist. And some OBGYNs, I mean, they Johnny on the spot. They can give it all to you and give you all of your options and you feel real comfortable and confident with them. I mean, some women have been with their same gynecologist for their entire life, right? Since teenagers or whatever. The research starts at home, though, with your symptomatology. So I tell patients, even though we don't want you to walk in the door with a diary and 10 pages that you're going to read to us and be like, okay, so in September on 15th, I had one spot of blood. Like, I don't want that. But for you and to have a good understanding of the pattern of what your body does, keeping a diary is not a bad thing. And there are apps that can help you do that nowadays. So track your symptoms. And I don't ever mind Google. There's some doctors that's like, Dr. Google ain't got no degrees. I don't mind Google because guess what? If something's going on with my child, in bed, 2:00 in the morning, I'm going to Dr. Google. So I've never, ever, ever shamed my patients for bringing to me the research that they have found to say, these are my symptoms. Because sometimes many women will diagnose themselves. And then sometimes they'll walk in the door and I'll be like, no, boo, let's start over. Let's get to it. Yeah. That is fine, though. I want you to have a healthy interest in what is going on and understanding your body, right? So just looking up your symptoms, there's no harm in that, and starting that process, as long as you're open to have that discussion with your doctor and not kind of corner yourself into one diagnosis, open up that door and say, okay, let's really actually evaluate this. So when you go to the doctor and you present with your symptoms and whatever investigation you've already done on your own, then the next part of the conversation needs to be, what is my workup? Not what is my treatment? Right. So I get so dismayed when I have these patients that walk in like, okay, I told my doctor I was bleeding heavy and that I noticed my menstrual cycle changed and they put me on birth control pills. And I'm like, okay, so what did your ultrasound show? They didn't get an ultrasound. Oh, okay, so what is your blood count? Are you anemic? I don't know. Nobody checked. I'm like, okay, what is your prolactin level? Or what, you know what I mean? Like, are your thyroids okay? Because endocrine disorders can cause you to bleed heavy. It can have nothing to do with the gynecological system. And so that lack of just a workup, by the time patients get to me, usually they've gotten the workup because you're not even going to make an appointment to come see me if you haven't had imaging, to be honest with you, if you haven't been diagnosed. But along the way is the frustrating part, and it's where we will lose so many women because they feel like nobody's listening to them. Or they're just throwing treatment at them and nobody has done the workup to actually get to what the problem is. And like you just made an example of it. Sometimes there's more than one thing going on. Sometimes your infertility is your fibroids and your tubes. You know what I mean?
Yeah.
So bring the doctor what you have, ask the questions about the workup first, and then go over the treatment options. Based on this or based on, what we found in our workup, what do you think my options are? And maybe even just tell me what all the options are and the pros and cons and why I'm not a good fit for that one, but you recommend this one.
Gotcha.
That's healthy.
That's good stuff.
That's good to know, right? I go over every option. Every single one of my patients leave out the door and they know what a uterine artery embolization is. They know what radiofrequency ablation, myomectomy, hysterectomy. They know they know all the medications to treat fibroids. Even if I'm like, you've had a DVT, so you can't do this one. They know they can't do this one because they've had a DVT. You know what I'm saying? I didn't just say, I'm not even going to just tell them about it. They know everything that's out there that they might read on Dr. Google and why it's not a good fit for them and why it might be something they need to consider.
Well, listen, I think that, because you do such an in-depth job of educating your patients, I think that speaks to why you have such high reviews on Google, and, in other places. So, I mean, kudos to you and kudos to the women who have sought you out, because, I mean, that is key. It's like you actually care. And I think that finding a doctor who actually cares about, the well-being and the education of their patients is key. So for all the folks that are in the Atlanta area, definitely seek out Dr. Hawkins for
anywhere you are.
Anywhere you are in the world. Come see her.
I will talk to you anywhere you are, because I think that another thing that we don't do is go outside of our community or go reach beyond what feels like it's just reachable. Sometimes, I have patients from Canada. I have patients from the Bahamas. I did surgery on someone from the Virgin Islands last week. I have a patient coming from the United Kingdom next month. You know what I mean? So it is not just your back door. And for people to understand just in my example, what a minimally invasive gynecological surgeon is, I'm not the only one. There are many of us out there, but it may not be right down the street in your neighborhood. Mm-hmm. So knowing who the specialists are, who might be more in if my child needs to have this, very, very in-depth surgery on his teeth, I'm not, maybe the family dentist isn't the right person for me to take them. So reaching beyond just what you know and where your comfort level is sometimes is necessary. And it's not, you shouldn't be shamed for doing that. And your doctor, if they want the best for you, they want the best for you, even if they're not the best. I tell my patients that all the time. I want the best for you. If I'm sending you for a UFE, I don't do that. But we've come to agreement that that's going to be the best thing for you. And I'm happy to make sure that I nourish that no matter what it takes. So I see and I accept patients from anywhere. I do virtual consultations, just like we're sitting here talking to each other now. This is how I talk to them. And I don't want them to, I don't want patients to listen to this and go back to their doctor and be like, why don't you sit and talk to me for 45 minutes? Not every doctor can do that. I fashion my practice so that I can do that. Mm-hmm. You know what I mean? A typical OBGYN might see 40 patients in a day. I see 12. 10 sometimes, because I want you to get your time to sit and talk, but I fashion my practice like that, right? I'm not making money delivering babies. To me, it's about the education and it's about the resources and it's about, getting patients. That's the way that I fashion, and I've taken the time out of my life and made a lot of sacrifices because this is ministry to me. So every doctor is not going to be able to do that. It's okay. But seeking a specialist it's to me, it's something that we should not be afraid to do. Period.
Absolutely. So I guess I have one last question. So I know that recently, I think that it was in August of this year, there was a bill that was passed. I think that there's maybe $21 million or so for the study of uterine fibroids and creating more options. Why has there been so little research that's been done? And this is huge and affects the lives of so many women. So many women, like people missing days of work because they're bleeding so heavy they cannot leave their bed.
Yeah. You see my smile is wide. That is our vice president-elect.
Yes.
She did the thing with that one. And we, legislature advocacy work is a part of what I do as well. I work with the White Dress Project here in Atlanta, which is a national organization. And I have a special place in my heart for them because the advocacy work that they do, and there are many organizations just like them that do different levels of this. So shouts out to all of them. But the advocacy piece is so essential to answer that question that you just asked, like, why aren't we talking about this more? Why aren't we making more of a fuss about this pandemic? It's a pandemic.
It is.
Why are we not getting the research and the funding? Why are we not answering the questions about how do environmental factors affect fibroids? Like, how do lifestyle factors and the food we eat? Like, why are those not big studies? The NIH has some smaller studies. Like, why are we not doing this on a national level? Like, why are we not answering these questions about what's affecting such a large part of our population in ways that are affecting our productivity? You know what I mean? They're affecting our mental health. They're affecting so many components of just life. So we're getting there. That bill is super exciting because one is putting it on a national platform for people to even just ask the question of why did she want to do that? Why did she want to push this bill forward? How important is this here subject? I recently did a Good Morning America series talking about the importance of fibroids and disparities in the way that Black women are treated for their fibroids. Like, why is it disproportionately that Black women are getting hysterectomies and sometimes that's the only thing they're being offered? Like, why is that? So we're starting to answer those hard questions. It kind of feels like, especially for someone like me and you, that we had our fibroid journey several years ago, that is like, okay, we weren't even talking about it like that. Maybe like in 2011, I ain't had no Facebook group to go to. Right. Like, okay, what did y'all think? Or I felt alone.
So alone.
I felt alone. And it was a whirlwind. You know what I mean? I felt alone in it, and I felt somewhat ashamed in it, and I felt like I was a newlywed and I was scared. I was like, my husband might leave me. What is my fertility going to be like? He didn't sign up for this. We didn't know it was going to be like this. And at the time, I didn't feel like I had any, I didn't have a white dress project. You know what I mean? I didn't have a faith in a podcast to listen to and answer my questions. I didn't have a Facebook group. And so all of these things that are now coming out of just giving this a voice is going to be huge for women, period. Every community of women that suffers with fibroids, every family, because who doesn't know someone that doesn't suffer from fibroids? Who doesn't know at least one person that suffers from fibroids? May it be their coworker that they notice is out every 15th and 16th of the month. You know what I mean? They got to check behind their seat when they get up from the meeting because they might have left a puddle of blood. You know what I mean? So everybody knows, just about everybody knows someone that's affected by this disease process.
And, I think that because fibroids is kind of like this, it's an unseen chronic disease, like from the outside looking in, you can't tell that someone is having a lot of these issues. And it's like you suffer in silence. And so it's like, that's why I'm doing this podcast. It's like, I just want, if there are 2 women who listen to this episode and feel encouraged, then that means that my work has been done.
Yes,
so
Lord.
I am so appreciative. You have no idea. When I got your response, I was like, oh my gosh, I was crying. My husband came in there. He's like, what is wrong with you? I was like, she said yes. And so it means, like, when I say that it means the world to me, it means the world to me. So thank you for taking the time to invest in having this conversation. I'm all emotional. It's the hormones too, I think.
I know, right? All right, I'm a crying doctor, so it's fine.
My doctor was laughing at me when I had my cesarean with my daughter, my first daughter. She was like, I sat on the table and she came in there and she said, babe, why are you crying? I said, because I never thought this day would come because everybody told me that it wasn't possible. And she said, now you can't be having me crying again this time. And I was like, I'll probably be crying again that time. Who knows?
I love it.
Well, I hope that this interview with Dr. Hawkins was insightful and helpful to those of you who may be dealing with fibroids and really trying to figure out what your next steps are. It was definitely a reminder to me about my long journey and my dealings with them, but also a wonderful reminder that after the storm, there's always a rainbow. Again, if you enjoyed this episode, be sure to share it widely and largely. Like Dr. Hawkins said, who doesn't know another woman, be it a friend, a family member, or coworker, who is or has suffered with fibroids? Ladies, we've got to have real conversation about what's going on below the belt to not only raise awareness, but to also destigmatize our suffering as women. Know that you're not alone and that there are a plethora of options out there for you to make an informed decision about what's best for you. Be sure to check out part 2 of my interview with Dr. Hawkins as she discusses symptoms, getting a diagnosis for, and treatment options for endometriosis. Peace. Thank you so much for listening. It is truly my hope that you both enjoyed and gained something from it. And if so, be sure to share this episode with another queen that could benefit. Also, if you are willing and able, please leave me a 5-star review wherever you consume your podcast. That is how we spread the good word, y'all. And in the meantime, be sure to follow us on all social media platforms at the Sister Circle Podcast. And be sure to check out the website, thesistercirclepodcast.com. There you can subscribe to our mailing list to ensure you get reminders about when new episodes drop and receive our monthly newsletter that's filled with great resources. You can check out our show notes, resources, and blog. And you can send me a message if you want to be on the show, have an idea for the show, would like to collaborate, or sponsor the show. With love, Faith.